Hello, I'm Lindsay Hausner and I live in Chicago with my husband Ross, who's sitting over there, and our son Aiden James was born still at 38 weeks on February 20th, 2016. And there's not a moment that goes by that we don't think of him, love him, and miss him more than anything in the world and just wish he was here. And I am honored and pleased to introduce our keynote speaker here tonight in loving memory of Aiden. Dr. Jane Warland is a registered nurse, midwife, and associate professor in the School of Nursing and Midwifery at the University of South Australia. Since suffering the unexplained full-term stillbirth of her daughter Emma in 1993, she has been a passionate researcher into preventative and modifiable risk factors for stillbirth, as well as a strong advocate for promoting public and maternity care provider awareness of stillbirth. Dr. Warland practiced as a nurse midwife for 30 years before commencing work as an academic in 2008. Her program of research is stellar: stillbirth teaching, epidemiology, loss, learning, awareness, and risks. Since becoming an academic in 2008, she has had more than 60 publications and has presented her research at more than 40 conferences, both national and international. We are honored this evening to welcome Dr. Warland, who is presenting a keynote address entitled, "I Have a Dream." Please help me in giving her a warm welcome.
I'm a hugger. Well done. Thank you. Sorry about before. I was completely blindsided. We were talking this morning about being blindsided. Boy, did that award blindside me. Thank you so much for nominating me and for voting for me. is usually the mother's fault. And again, across the globe, we've got people agreeing with that statement. In high-income countries, less so than in low-income countries, but still, we've got people across the globe saying, yes, it is the mother's fault. Then we've got a sense of helplessness. We can't prevent it, and why should we try? I'm not sure that that's true either. But certainly, again, in this survey, we've got people agreeing with the statement, many stillbirths are preventable, and disagreeing with that statement too. And the very last one, and one that's actually quite dangerous, and one that I encounter all the time, is I'm not going to talk to my women about stillbirth, especially if they're not at risk. Have you heard that? Have you heard that people saying, care providers saying, well, if my woman is not at risk, I'm not going to talk to her about stillbirth. Problem is that, as Alex was saying today, a lot of stillbirths happen in people who have absolutely no risk factors at all. So if the care provider is only talking about stillbirth in people who they think is at risk, then that's keeping a whole pile of people in the dark. It's a good analogy to be talking about SIDS and stillbirth and what happened in SIDS campaigns and SIDS awareness worldwide, comparing it with stillbirth. So if you think of SIDS, there's no known cause, it's probably multifactorial, there's certainly the potential to make people anxious. Same thing with stillbirth. There's no known cause, it's probably multifactorial, and we do have the potential to make people anxious with that message. But what can we learn from the success of reduction in SIDS? I think that we still don't know what causes SIDS, and we really don't. But we certainly have worked out how to protect the vulnerable baby by recommending that all babies are put to sleep on their back. And across the globe, we've seen a massive reduction in SIDS as a result of that message. It's a public awareness campaign that worked really well and a simple, doable message. So can we bring that into stillbirth? I think the answer is yes. And I'm going to talk to you about some of the reasons that I think that that's so. But before I do, I think a public awareness campaign, you need to be really aware that the public health promoter asks, why might the audience be motivated to do what you're asking them to do? And in order to persuade people to do something, we must first make them aware of the facts, the issue, and give them the facts. Facts like how common stillbirth is. If we don't do that, if we say something like, we want you to settle to sleep on your side, and we don't say why, then we won't have people doing it. So we actually need to be giving the reason why when we give the public health message. What's the message? Well, again, I think we've got some disagreement, certainly in Australia, about that message. And it's actually held us up. It's actually prevented us from going ahead and giving a public health awareness message in Australia because we're not quite sure what we should say. But I think it's simple. I think that we need to be talking about the why. We need to be talking about awareness and the awareness of how to protect the baby in getting to know and advocating for the unborn baby. We need to have an F, which is fetal well-being. And as far as the mother's concerned, that's movement. And I think that we also need to empower the woman to act. Because there's no good her being aware and thinking, oh, that doesn't feel right, and then feeling too scared to do anything. So, it's a pity that Alex isn't here actually, because Tommy's, I think, is leading the world in public awareness of stillbirth, and there's a lot that we can take from the Tommy's messages that have recently been launched. So this one, who's seen it? Only a few of you. I'm going to show you the shortened version of this campaign. It's a campaign which is basically saying to the woman, trust your instincts, seek care if you're thinking that something's wrong. So here's the 1 minute, which I hope works, version of this. We've got it. Just pull it down a bit.
There we go.
Oh, well done. Can you make it louder?
Knowing what's normal for you makes it easy to spot changes that don't feel right. And if something feels wrong, speaking up is important. Others can spot changes, and they can speak up for you too. It's easy to worry about being a nuisance, time waster, fuss about nothing, over anxious, troublemaker, frightened. But really, what's the worst that can happen? We'd rather reassure you 100 times than miss a problem once. No one should worry about speaking up in pregnancy. Be your inner champion. Please share.
Okay, so in Australia there's a group called Still Aware, and they have got a education campaign that's running on television out of hours. That's all they can afford. They're a self-funded organisation, something like Star Legacy, I guess, here in this country, but focused entirely on awareness. And I did want to show you that video. With that last experience, perhaps I won't. Basically they're just saying, be aware, your baby should be moving normally, and if it isn't, then take care to notice the change and report to your care provider. So that same sort of thing of stillbirth happens, be aware and advocate for your baby and be empowered to act. The last awareness campaign that at least I'm aware of in the world is one in Wales. Again, it was reasonably recently launched. So this is exciting to me because awareness campaigns being launched means that across the globe we've made a decision. Let's talk about stillbirth, for heaven's sake. Again, this includes elements of the kind of public awareness campaign that we need. In that purple line at the bottom, it says how many babies are stillborn in Wales every year, I think. No, it's 1 in every 200. So that's the thing that they cite. And then they're basically saying how they suggest that you keep your baby safe and the kind of things that you need to talk to your care provider about. So again, a simple message, not necessarily scary, empowering for the woman, in my humble opinion. So what I wanted to do was to read you a quote that when I read it to Louise, she said, "Oh my God, Jane, you could have written that." And she's right, I could have, but I didn't. One of the STARS study participants did, so here's what she said. "There's not enough education or awareness about any of the risk factors or about stillbirth in general. I went out seeking as much general information about pregnancy as I could get, and also about some of the risk factors in particular, and still did not find anything that made it clear that I could be in trouble. But I do strongly believe these signs were there, and I would have caught them if I knew what to look for. My baby girl should be alive right now. I feel that the public health system failed us." Who agrees with that? So, what can maternity care providers do? Maternity care providers need to supply information, support, and be aware themselves. Now we can't stop that payment. Awareness of risk, advocacy, and protecting the woman and her baby by paying attention to fetal growth. Listening to women when they report changes in their fetal movement, maternal intuition, and maternal sleep position. So awareness of risk. Alex again would tell you that currently we've got a range of risk factors for stillbirth, but a lot of them have modest effect sizes. And what that means is that it doubles or trebles or sometimes quadruples the risk of stillbirth. But if the risk of stillbirth is 1 in 200, then it really just means even if you've got double the risk, you've got 1 in 100 chance, so still 99 babies are going to be born alive and well. And also, I think that it really needs to be understood that the factors interrelate. So this triple risk model that Ed Mitchell and I developed after the last Stillbirth Summit in, well, the first one actually in 2011, shows the interrelationship between the factors that we think need to happen in order for a stillbirth to occur. So if we look at, who's looking at which one? If we look at, perhaps I'll use the cursor. Can you see the cursor if I do it? No, okay. All right, so if we look at fetal vulnerability as a circle, maternal factors and the fetal stressor, what we see is where those interrelate, you get stillbirth, we think. But one of the things that we really need to point out is the numbers of babies who are out here. So they're vulnerable to stillbirth, but it doesn't happen because, thank God, most babies are resilient. Lots of women have lots and lots of things that's wrong with them, that's putting them at risk of stillbirth. High BMI. Some of the lists on here: advanced maternal age, first baby, that sort of stuff. And then we've got some sort of stressor as well. So we think that if you figure out how to protect the vulnerable baby, identify and protect the vulnerable baby, but even if you can't identify, perhaps if you can protect the vulnerable baby, that you'll end up reducing numbers of stillbirths. One of the things that care providers need to be aware of is risk factors. And I thought that I would try a quick poll. So Lindsay, I need your help. What I would like you to do is have a look at this slide, which I have shamelessly purloined from Griffith University, so that's why it's got Griffith University on it, for risk factors. So have a bit of a look. Can you read it? Yes? People are just going with 10. What are there, 10 dot points? 2, 4, 6. Oh, yeah. Okay. Continue to poll because we'd be kind of interested in what everybody thinks. But again, I've got anything from 0 to 10 with a bit of a cluster around 3 to 4. She has 7 risk factors for fetal growth restriction. Her age, the inter-pregnancy interval, the fact that she's had a previous small baby, the fact that she has a low PAP-A, the fact that her husband was a small baby, the fact that she has a low BMI and that she's a gym junkie, all put her at risk for a small for gestational age baby, right? One of the neat things that have been done in the small for gestational age space are that we have major risk factors and minor risk factors for that. And here we have a list with ones for Mrs. Sullivan in highlighted in red. But there are certainly places now in Australia who are saying that at the booking visit, the first intake visit, if a woman has a lot of those major risk factors, she should be managed differently throughout the pregnancy. More testing, more scans, more looking at her carefully to make sure that she doesn't repeat the performance. The interesting thing about risk, though, is that if you look at Mrs. Sullivan's risk factors for fetal growth restriction and for stillbirth, then they only overlap, only 2 of them overlap. That doesn't mean she's at limited risk for stillbirth, nor does it mean that she's not at the increased risk for small for gestational age. It's just a really good example of how risk works. It's not a certainty. She might be at risk, but it doesn't mean it'll happen to her, and it certainly might not happen to her depending on how she's managed in her pregnancy. So all of that is predicated on us detecting and managing that risk. So overall, the risk factors, the risk for fetal growth restriction, having an adverse pregnancy outcome, which includes another small for gestational age as well as stillbirth, is 4 times increased risk. But, and it's a fairly big but, we've got a pretty big problem, and Apollo 13 is one of my most favourite movies in the whole world. The problems are that we need to know how to find the preterm sick and small to deliver, and to leave the well constitutionally small to gestate, but mindful that we're going to watch them. And then we need to find the term sick baby to deliver. And that's not necessarily the one that's hit the 3% percentile. And also we need to find the growth restricted, apparently not small baby, who many of you in the room might have had, and I certainly had one of those myself. So this comment, which I will read because I relate to it, the baby I lost was small compared to my other children. So we completely find ourselves it's very, very difficult for us to find those babies. The other thing is the tools that we have. So we have to find this baby using nothing but a tape measure and perhaps an ultrasound machine. And we've got debates. So we've got people who say you measure the symphysiofundal height from the fundus to the symphysis. Guaranteed. And then you've got people saying, no. You measure from the symphysis to the fundus. And those 2 groups of people won't agree. Then we've got people who say, when you chart it, you need to chart it on a customised birth chart, otherwise you'll miss some of the growth restricted babies. No. Others say, no, you have to put it on a population-based growth chart, and then you'll find the babies that you're going to miss. So we've got those debates. And we've also got this. I found this manuscript by a lady who was talking about defining abnormal fetal growth. And she says, whatever method is used, the benefits of detecting fetal growth disorders can only be realised if we can effectively reduce the risk of complications. At the moment, delivery is the only way of doing this. And in some parts of the world, delivery isn't on offer in this country until 39 weeks. Let's use, even using optimised charts and thresholds, we are likely to over-intervene in many normal cases to prevent complications in the few, and that's the reality. Ultrasound assessment of fetal growth has limitations, and better methods of risk prediction are needed to prevent death and disability in babies. Got to agree with that. Is there a better method on the horizon? Yes, there's a lady called Susan Walker who has won a large grant in Australia, and she's actively trying to find circulating placental RNA in the mother's blood as a way of helping her and her team to predict who's going to be small for gestational age once they hit 26 to 30 weeks. So there's promising stuff on the horizon. I was talking to Manna earlier, and she was saying that other places in this country are also looking at free cell markers. Not my field, but exciting nonetheless. So moving away from that to fetal movements, we know, and we've known for the longest time, that if you experience a decrease in fetal movements, that puts you at increased risk of stillbirth. The STAR study has confirmed that, and I'll be presenting a little bit on that in a minute, and also on Friday. So the summary of the STARS findings to do with fetal movements that we have at the moment, and we have a paper under review that Alex Heasel has written. We found that the controls were more likely, the live-born controls, were much more likely to check fetal movements that they were much more likely to be told by their care provider to keep an eye on their fetal movements. And the cases were much more likely to report significant abnormalities in fetal movements in the 2 weeks before the stillbirth, so not necessarily immediately before, but in the 2 weeks before, with a significant reduction in fetal activity, a huge odds ratio, nearly 12-fold risk, a sudden single episode of excessive fetal activity, described by the mums as crazy, wild, ballistic, nuts, frantic, those sorts of words. The cases were more likely to report frequent daily hiccups, and that the hiccups lasted more than 5 minutes. And those findings actually came to us directly from the first Stillbirth Summit, where some people put up their hands and said, "My baby went crazy. Did anybody else experience that?" And other people in the room saying, "Yeah, that happened to me too." And because of that, we now have solid evidence that we can say stillborn mums experience this, and it puts you at 4-fold increased risk if you experience it. Can awareness of decreased fetal movements be protective against stillbirth? Well, we think it can. And I really don't have time to go into this, but there was a large study conducted in 1989 where people were just told to keep an eye on fetal movements and count to 10, and both groups in this large randomised controlled trial of 68,000 people experienced a reduction in stillbirth. So that certainly suggests that it really doesn't matter how you keep track of the baby's movements, the thing is that you do. We've also got some very exciting things happening in Scotland. In Scotland, there was a maternity and child quality improvement collaborative set up in 2010, and they had an aim that by 2015, 95% of all pregnant women would have a documented conversation with a midwife about fetal movement towards the middle of the pregnancy. And what's happened in Scotland is a reduction in their stillbirth rate, a significant reduction. And they say that it's dropped and that really no one factor can be attributed to that reduction, but it certainly makes sense to attribute some of that reduction to the fact that maternity care providers have to have a conversation in the middle of the pregnancy, telling the woman about fetal movements. Then we have the naysayers who say, well, if you talk to women about fetal movements, you'll make them anxious because you have to tell them why you're asking them to pay attention, and that'll make them anxious and upset about being told about stillbirth. So there was a large study in Norway which completely disputed that and actually found that if you talk to women about fetal movements and you have an appropriate response to that fetal movement reduction, that you actually drop your stillbirth rate without making women anxious. But, and it's a pretty big but again, there's this huge myth, and again it's across the globe, and I really don't know where it's come from, and it's awfully dreadful that it's happened. It's normal to feel less movement toward the end of pregnancy. We saw it in the 2 comments that you see there from the STARS study, and it's certainly something that I just hear all the time from bereaved parents. It is not normal, of course. Fetal movements don't normally decrease close to term. In fact, if they do, that you're at substantial increased risk of stillbirth. Next one. Women who experience decreased fetal movements should be told to sit down and drink a cold or sweet drink before coming into care. Again, really endemic across the globe. Not true. Doesn't make sense actually if you think about it. I talk to my students about it, and initially they'll say, yeah, I've heard my midwife colleagues talking about that. And then I'll say to them, but think about it. If you have a cold drink of water, how on earth is that going to make the baby move? Because the minute it hits the stomach, it's going to be warm. So that makes no sense to me. And then they go, oh, well, it's the sugar in the orange juice or the whatever other cold drink you're going to be drinking. And again, if you think about that as, how does that work? The woman drinks something sugary and the baby moves. The only way that that could possibly work is if there was some sort of sugar load that goes over to the baby when the mother drinks something sugary, right? That's the sort of the theory, I think. Thing is with that, again, if you think about it, if the mother isn't diabetic, her pancreas is going to deal with all that sugar before it sees the baby. Otherwise, the baby's going to grow enormously big because it's getting all this sugar that it needs to mop up with its own pancreas. So it doesn't work physiologically. And even if it did, it still doesn't make sense, because even if it did make the baby move, it doesn't make the baby well. So if you think about yourself, you're lying in bed feeling a bit sick, got a bit of a headache, got a bit of a cold, something like that, and somebody gives you a drink of cold water, here, this will make you feel better. Might make you feel better for a minute. Does it make you well? No. So at the absolute worst, it's dangerous, because it's delaying the mother going to care, and it's making her think, oh, I drank something, the baby moved, everything must be okay. Then we've got a myth that says a well baby moves 10 times in a period of time. Who's heard that myth? 10 times in 10 minutes, 10 times in an hour, 10 times in 2 hours, 10 times in 4 hours, 10 times in a day, 10 times in a period of time. Again, not true, guys. And I've got an example which I would like to show you. Let's just hope this works. It's of my unborn baby Bethany moving. What I'd like you to do is count how many movements you see in this very short video, and then we'll have Lindsay with her special whiz-bang thing. Is she still in the room, or does she go to bed? She's gone too, everybody's left. Okay, we'll go a show of hands. Oh no, you're there, hello. I don't have this one yet. Oh, you don't have one? Oh, okay. We'll just do a show of hands. Okay, ready? Let's hope it works. Go. Not counting the dog. I think it might be on circular. It's going on for much longer than normal. Okay. All right. How many? 4? 6? 10. Any advances on 10? 12. Did anybody think 1? There's always one in the room who goes, that was one episode of movement, we'll have 10 more of those, thanks. So, we've got a pile of really quite well-educated people in this room who think lots of different things. It's hard to tell. You're not in her body. She's breathing. But the fact of the matter is that if she rang the hospital and said, my baby's not moving normally, and the midwife said to her, has it moved 10 times today? And she was being honest, she'd say, yes, but the baby's not moving normally. So we have to get that number 10 out of our heads. It doesn't serve us well at all. Instead, I would propose that we have a completely different way of thinking about fetal movement. And it's concerns frequency, strength and pattern that together equal fetal well-being. Now, if you're a care provider in the audience, you'll know that if a woman is in labour, we ask her a number of questions. We say, how often are you contracting? How strong are they? And are they regular? Is there a pattern, right? If we said to her, just interested in how often you're contracting, what does that tell us? Virtually nothing. Doesn't tell us whether she's in labour, doesn't tell us anything really. So that's how we need to think about fetal movement. Fetal movement is made up of the number of times the baby's moving, how strongly the baby's moving, and the pattern for that movement. And those three elements together equal fetal well-being. And if you just ask, is the baby moving? Even if you say, is your baby moving normally? That's not the right question, in my humble opinion. And I've got the stage. You need to be saying, tell me about your baby's movements. Because then the woman will tell you about her baby's movements. Frequency, strength and pattern together. And if you ask her that, is Manny in the room? Manny Ganciano? I stole this from him through Joanne O'Leary, but I love it. And it is, if you ask the woman to tell you about her baby's movements, then that empowers her to be aware of who her baby is, how her baby is, and to immediately report to you if there's a change. And that's what we need as care providers. And that's it's the information that we need as parents. So what do? We need a paradigm shift from taking sit down and have a drink and call me back if you're still concerned, completely off our list of things to do, and instead say, I'm concerned that you're concerned, come on in. This empowers the woman, and it means that you've listened to her and appropriately responded to her concerns by appropriately assessing her baby's well-being. And it's important because this quote is another one that I reckon I could have written, but I didn't. It came from a STAR study participant. I wish that my OB had told me about kick counting and to notify her if his movements became less frequent. I wish I'd been educated about how common stillbirth is and what the signs of fetal demise are. I truly thought it was so rare that it couldn't happen to me. Healthcare professionals don't want to make expecting mothers overly anxious and paranoid, but they do need to make them aware of signs of fetal demise to watch out for. How's my time going? 20 left. Maternal intuition. Who in the room believes that maternal intuition exists? I've asked that question across the globe to a variety of different audiences, and I always get a really strong response. Yes, we believe maternal intuition exists. Then I talk about maternal intuition in pregnancy, and everybody goes, oh, I'm not so sure about that. But the person's a mother. She's having a baby. Anyway. So, in the STAR study, we asked, during this pregnancy, did you ever have a gut instinct that something was wrong? And in the really large historical cohort that we had, 65.5% of them said yes. Huge numbers. Alex, bless him, said, must be something to do with from time since stillbirth. They're, remembering it or remembering it differently from how it actually happened. No difference found. Then he said, oh, it's probably the multips, the people who'd had a baby before, who felt it more than the people who'd never had a baby before. Actually, it was the opposite. So we had more people who had not had a baby before say yes to the question. So interesting. Then in the case control, we've got an even stronger finding. So we had 75% of the 146 stillborn cases say yes, and we had 29, which is 12% of the 234 live-born controls, say yes. We had some themes, and I think that the most interesting is when the gut feeling occurred. So we had about 20% of the women say the gut feeling occurred right from the beginning of the pregnancy. I found out I was pregnant and immediately thought, oh, something just doesn't feel right. Told my care provider about it, they said, don't be silly. Told my husband about it, he said, oh, you're just being anxious, dear, don't worry about it. And then ended up with a stillbirth, right? Happened to me, and I'm sure by the nods in the room it's happened to some of you as well. There were other things which, again, I really don't have time to go into, other themes that we'll report in an open access journal. But really the woman tended to put it down to anxiety, first time mum jitters, that kind of thing. She had dreams about it, vivid dreams, dreaming about having a stillborn baby, and then wrote things like, I wish I'd listened to myself. And then telling someone and being reassured, as it turns out, falsely. So what can we do about it? Well, I think we first need to understand what it is. Everybody in the room has to go, this is my daughter Kate and my grandbaby Mabel. Thank you. Mother's intuition is the natural inborn intelligence that guides and supports the mother to deeply know, without external influence, what is truly right and correct for her child's best interest and well-being. And we all know that that exists. And we see it in practice. So paediatricians in the room would recognise that you can't ask the baby or the pre-verbal child what's up, so you ask the mother, don't you? And if the mother presents and says, something's wrong with him, can't quite put my finger on it, but he's not behaving normally, it's a very stupid paediatrician indeed who would go, you're just being silly. Don't worry, it's normal to be anxious when you're a mother. It's not something that we hear. But obstetricians say it to their women all the time. I've got a gut feeling that something's wrong. Don't worry. Settle back, relax. I'm in the driver's seat. Don't worry about that. And I think that really we're in the same position as the paediatrician. Well, we should be. We should be listening to the mother. She's saying something doesn't feel right. Trust her. She's a mum. How can we use it? I don't think we'll ever see, IOL stands for induction of labour. I don't think we'll see induction of labour for maternal intuition anytime soon, especially not in this country. But it is my hope that when we publish these findings and talk about it more, that there'll be a movement, I guess, towards understanding that we actually do need to listen to women when they say something's wrong, even if it's nebulous. So I really want to read this quote to you. It's quite long, but boy, it's a good one. I worried throughout my entire pregnancy, but I seemed to be having an absolutely perfect, healthy pregnancy. So I kept telling myself not to worry. When we hit 37 weeks, I pretty much stopped worrying because I figured if anything went wrong, they'd cut me open and my baby would be fine. I never even knew stillbirth was a possibility. I'd done tons of research on pregnancy, read all the books, took all the classes. It never came up anywhere. I thought stillbirth had ended in the 1800s. I never knew how common it was until it happened to me. So even though I sensed something was a little off, I was reassured by everyone's confidence in my pregnancy. I thought it was just normal worries. If I'd really felt anything was wrong, I would have trusted my instincts, but whatever instincts I might have had were mild enough to be easily dismissed. It's hard to gauge in retrospect. I'd like to think I knew something was wrong, but really, nothing felt wrong enough for me to act on it. It seemed normal. Yes, right from the beginning. So, not listening to my gut will always haunt me. is not something that I as a care provider want to hear. So I think that we need to say to our women, sometimes women have a gut feeling that something is not right during the pregnancy. And if this is happening for you, can you please just let me know so that we can work together to keep your baby safe? Scary? I don't think so. And then listen to what she says, because we've got comment after comment after comment saying, I wish my care provider had listened to me. How much time have I got left now? 10. Okay, on time. Maternal sleep position. We've got people in this room who've conducted this research. So I'm certainly not going to rain on their parade or tell them how to suck eggs. But we've now got 4 studies internationally that show that supine sleep is bad, and non-left-sided sleep might be bad too. We think that it's probably because there's a large vein, the inferior vena cava, that's going down and could be being compressed. But we also have clinical experience that care providers use all the time. So this is actually from a non-stress test that I did when I was a practicing midwife, so it's a little bit old, but physiology doesn't change. And that is, this baby was going along very happily until it wasn't happy, and my immediate resuscitation, which I've circled there, was to put the baby left lateral. That if you turn your head on the side, you can see that I've scribbled left lateral onto the CTG as it was moving along. And then I gave her some oxygen and increased her IV, and gradually the baby returned to normal. So we do that every time. Any midwife in the room would have done that hundreds of times as a resuscitation for the baby who's upset. She was on her back. We moved her to her side, the baby recovered. So we see it in practice. So we take a great deal of care to tell the women during the day to avoid the supine position, but we don't do it at night, even though we spend a third of our pregnancy asleep. Does that make sense? Not really. The other thing is, hot off the press, is what's happening in New Zealand. That we've gotten really good at managing women when they're in labour, or it's something to do with the age of the mothers, and we're getting less teenagers in the mix. But none of those explanations actually explain why suddenly there was a drop in 2011, because they didn't suddenly get good at smoking education in 2011, and they didn't suddenly have a sudden drop off of teenage pregnancies in 2011. But what did happen in 2011 was that Thomasina Stacey, who is a midwife, New Zealand midwife, published her PhD findings, and it was the first in the world paper, and she published that there was an association between maternal sleep practices and risk of late stillbirth. And there was this global explosion. You might remember it. There's all these people going, this is good, this is bad, this will worry people, this is crap, this is fantastic. There was all these responses to this particular publication. And then Ed Mitchell came up to the summit in 2014, and he said, despite urging caution, midwives appear to have accepted the findings and are advising their patients to sleep on their left. Now you need to understand that in New Zealand, they have a midwife-run model of care. Just about all women see midwives. And it's a very small country and a very close-knit group of midwives who work together and know each other well. So if one midwife found this finding and then she told everybody else, and it makes sense clinically, then of course you're going to tell your women, which is exactly what Ed was complaining about in 2014. So there's been a significant increase in left-sided sleep position, and perhaps an associated reduction in late-term stillbirth as a result. Now again, just like the Scottish data, you can't say it's only sleep position, because it could be other factors, but it certainly seems quite serendipitous, doesn't it? As Ed says, it's tempting to believe that the decline is a consequence of more pregnant women sleeping on their left. How do we bring this into practice? I think it's really simple, and certainly since Leslie McCowan has published her findings just recently, there's been another flutter of activity, especially in New Zealand, and I've heard her say that we need to now be telling women to settle to sleep on their side. Don't worry if you wake up in the middle of the night on your back. That's normal. Settle back to sleep on your side. Again, a simple message, which I think is probably already in practice anyway. So, 300. In the time that I've been talking to you, 300 babies have died across the globe. That's not good enough. We need to raise public awareness of stillbirth. We need to let pregnant mothers know that advocating for her baby oh dear. You can read it. So, where to from here? Friday, we've got a session I'm running with Suzanne Pullen, and she and I are going to say, what do we do now? We've got these fantastic findings from the STAR study. We can't stop there. We need to continue, and certainly the quotes in the stars tell us that we need to continue. There's a lovely story that I'd like to finish with, and it's about the starfish. Have you heard it? It's about a little boy who's walking along a beach that's littered with starfish after a storm. And he's bending down and picking up starfish and chucking them back into the sea. And an older fella is looking at this and going, finally says to the little boy, what are you doing? And the little boy says, saving starfish. And the older fella says, you can't possibly hope to save all of those starfish. And the little boy replies, made a difference to that one. So we need to make a difference where we are. And if you make a difference, 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 together we'll make a big difference to the starfish on the beach. Thank you. Any questions?
Thank you, Jane.
Thank you.
Is there a standardized protocol for advanced?
Hang on, we'll just get a mic to you. Or you can.
Oh, no, we'll get a mic.
I'm just the question is about the slides you had about advanced maternal age being a risk factor for stillbirth and also growth restriction. It's my understanding there isn't a protocol in the United States that all OBs follow for advanced maternal age, patients of advanced maternal age. Is that true, number one? And how do other countries handle that?
I can't speak for the United States. Is anybody in the room able to speak for the United States? Okay. Certainly in Australia, there's no protocol for advanced maternal age, but we are aware, I think that it's probably the most commonly recognised risk factor for a whole heap of things, including stillbirth. So your care provider, if you were what's called an elderly primip. In Australia, would be treated as at risk more than if you weren't. Does that answer your question? Maybe. It's all I have to offer. We don't know that Bob Silver is coming, do we? Okay. Just trying to think who else would know. It's a question that I'll find out the answer to for you.
So we know here the 39-week rule is a limiting factor in care providers providing the care they might choose. How else can they handle things such as the hierarchy of a perinatologist giving orders above what your OB might suggest, as well as limitations of insurance being an issue of your care provider saying, I would give you that test, however, your insurance won't cover this?
Yeah. You know how I said that the woman needs to be empowered to be her own advocate? That is absolutely true for the United States as far as I can tell. I asked Bob Silver about this actually, and he's a really strong proponent of the 39-week rule. Ironclad, 38 and 6 won't do. And then I said, so if you have a woman who has had a previous stillbirth, she's complaining of reduced fetal movements, she's 38 weeks, are you honestly going to wait another week? And he said, no, in that circumstance I probably would go ahead and deliver her. So I said, so how would she get that done? And he said she would have to insist and cry. He honestly said that. Yeah, make your way to care and say, I'm not leaving until you deliver me, I'm worried. And it's a very strong care provider indeed who would then say, I'm sending you home, just don't leave. It's tough, and I really feel for everybody in the room who is battling with that rule, especially as it doesn't exist anywhere else in the world. I'm not sure that I've been able to answer your question really. Jim Nicholson is giving a talk on the 39-week rule tomorrow. Oh.
Speaking of which.
Speaking of him.
So really great talk.
Thank you.
When I talk with medical students at Penn State Medical School, I always talk about the preventive model, which involves defining the disease that you want to prevent, which in this case would be stillbirth, identifying ideally the full list of risk factors, but at least the major risk factors, number 2. And number 3, finding a time interval with which you can work, which I call the latent phase, and then coming up with an intervention that will effectively prevent the disease that you're trying to prevent. So when I hear you talking about reduced fetal movement, which I talk with my patients about now regularly, my question for you is, what is the recommended intervention model that we should be thinking about? Because I don't think it currently exists. So if a patient at 34, 35 weeks has reduced fetal movement and her provider does send her to the hospital, what would then be the ideal course of intervention and treatment? And I don't think it necessarily is just a single non-stress test, but I don't know beyond that what we should be recommending.
Yeah, so PSANS, the International Stillbirth Alliance have a set of guidelines for reduced fetal movements that's on the International Stillbirth Alliance website, and it's actually got an algorithm, presentation, movements, what to do, and it's certainly more than a single non-stress test, and it includes the statement that you don't send the mother home if she's not happy. So the bottom line is the mother. And again, I understand the problem with trusting the mother in your system, but that's what the algorithm says. Non-stress test. If that's looking a bit dodgy, off to ultrasound. If the non-stress test looks okay and the mother is now okay, she goes home. If the non-stress test doesn't look okay, she goes to ultrasound. If the ultrasound is looking okay, then she can be sent home saying, come back if you remain concerned. So that's the flow. Little known. I'm not surprised that you don't know about it. Any other questions?
Is that linked to that little commercial that we watched? Out somewhere?
So the little commercial that you watched includes fetal movement because it certainly is one way that the mum can keep track of her baby and be reassured that the baby is well. But it's also it also addresses that gut instinct actually, because it says if something doesn't feel right, go get yourself checked out. And it also talks about if other people look at you and go, you sure that's okay? Then you need to listen to them and go to care as well. So it's more than keeping track of what the baby's doing. So there's a 5-minute version of the 1-minute version that I showed you. It's really good. I would advise that you
And where can we
look at it.
find the link to that video?
If you Google Tommy's YouTube, you'll find it. Hashtag always ask is the name of the program.
Shauna mentioned that they'll put the link up on the Star Legacy website as well.
Oh, okay. Good one. Thanks, Shauna. Time for bed? What do you reckon? No? More questions?
One other question, is there any wearable tech that you're aware of that can like help monitor fetal movements or heart rates that would help identify some of these symptoms?
It's a really good question. It's one that I'm often asked. My personal view is that wearable devices need to be promoted with a great deal of caution because the mother might just trust it. So if she's thinking, something doesn't feel right, and the wearable device says baby's still got a heart rate, then she might go, wearable device says baby's still got a heart rate, I don't need to worry. But you have a heart rate until you don't. So that baby can really be on death's door and still have a heart rate. So wearing a device that says my baby's heart rate is beating isn't reassuring at all. So I would much prefer to say to the mother, it's important that you get to know who your baby is, how your baby is, and immediately report if there's a change, trusting her and her instinct rather than some kind of technology. It's my humble opinion.
I was just going to say, back in the 80s, they used to have a program where they had home monitoring for mothers, and they would put themselves on the fetal monitor, and it would go into a central office, and they would read it, but the outcomes didn't prove any difference, so they don't do it anymore. Sorry.
Okay. Were you here for Alex's talk about his rainbow clinic? He's seen 500 women and no stillbirths in that group. I think that there's more to keeping a baby alive and well than just monitoring movements. It's a holistic approach of looking after the mother looking after herself, the care provider being responsive, doing appropriate tests, delivering when necessary. It's not just one thing.
On your slide, it mentioned where you touched on just a little bit about increased fetal movement.
Oh yeah.
Is there much research out there about that, or what's the recommended? Say that's what you experience. And it's out of the ordinary, like you said, it's extreme.
So the question is, what about increased fetal movements and risk? In the STAR study, case control, we found that If the stillborn mums reported a increase, then they didn't talk about an increase in strength alongside it. Whereas if the controls talked about an increase, they did. So the controls said, my baby's movements increased and they felt stronger, harder, powerful. Whereas the cases said, my baby's movements might have increased, but they felt weaker and fluttery. So it was increasing, but it was fluttery. As far as the one single episode, we reported that and echoed Thomasina Stacey's study from New Zealand that was published in 2011, who also found the same thing. So she reported that if you have a single episode of vigorous fetal movement, that you're at 7 times increased risk. We found it was 5, 7. It's still a big increase in risk. We're not exactly sure why. Alex has actually just won some funding to explore increased fetal movements and the reason why increase might also be a problem. But we're not talking about, it seems as if the well baby will increase frequency and strength and have that as a pattern, whereas the unwell baby might increase, but it'll become weaker and won't have a pattern to it. So those 3 things that I talked about, frequency, strength and pattern, being the things that you need to have all together to be sure that your baby's well. Does that answer your question? The first time mum is at risk anyway, so the 2 risks overlap. If you think about the triple risk model, she's got a risk with age and also a risk for her being the first time mum. So she's still got the age risk even if it's her second child. The first time mum risk comes out of the circle, but then she might have something else go in, or it still might be too much for the vulnerable baby. Okay. Once again, thank you for the award.